Which of the following is true regarding post-ME pericarditis? It occurs in a majority of patients with MI. B. Concave ST elevations are usually seen on EKG. C. Treatment generally involves nonsteroidal anti-inflammatory drug, NSAID, therapy. D. A pericardial friction rub is almost never audible. E. Etiology is likely infectious. The answer is C. Treatment generally involves nonsteroidal anti-inflammatory drug, NSAID, therapy. Answer C. Post-ME pericarditis generally occurs within 4 days of MI and is characterized by a change in the quality of chest pain. It is treated with NSAIDs in the same manner as idiopathic pericarditis. Less than a quarter of all patients with MI develop pericarditis. EKG changes are usually absent, masked by the MI findings. Pericardial friction rub is characteristic and often audible. The proposed etiology is autoimmune. Dressler's syndrome is the term given to pericarditis, which occurs 2 to 3 weeks after MI. It is clinically and electrocardiographically indistinguishable from ordinary pericarditis and should be treated in the same way. Applying a magnet to the chest of a patient with a pacemaker. Turns the pacing function off. B. Turns the sensing function off. C. Changes the pacemaker response to sensing from inhibition of impulse generation. D. Completely deactivates all functions of the pacemaker. E. Converts a dual-chamber pacemaker into a single-chamber pacemaker. B. Turns the sensing function off. Answer B. Applying a magnet to the pulse generator causes the pacemaker to default to a synchronous pacing function by turning off or bypassing the sense amplifier. In other words, a magnet turns the sensing function off. The pacemaker will deliver impulses, pacer spikes, at its predefined default rate, sometimes called the magnet rate, regardless of the heart's intrinsic electrical activity. The result is an irregular heart rate, since the pacemaker ignores the patient's intrinsic rhythm and is therefore not synchronized to the patient's intrinsic rhythm. A 35-year-old marathon runner who is asymptomatic presents from an outside hospital with an abnormal EKG. The EKG is shown. Your advice to the patient is: telemetry admission for pacemaker. B. Atropine 1 mg 4. C. Amiodarone 300 mg 4. D. Adenosine 6 mg 4. E. No acute therapy, routine follow-up. E. No acute therapy, routine follow-up. Answer E. The EKG demonstrates vent-batch phenomenon or Mobitz type I AV block. The PR interval progressively increases in length and predictably drops AQRS beat after the second prolongation. In the absence of symptoms of other serious cardiac disease, management involves outpatient follow-up. Pacemaker placement would be required for patients with Mobitz type 2 second-degree or third-degree AV block. Atropine is used to treat hemodynamically unstable bradydysrhythmias. Amiodarone may be used to treat a variety of tachydysrhythmias but is not indicated for patients with AV blocks. Adenosine is used to abort supraventricular tachycardias. A 59-year-old female with a history of sick sinus syndrome status post-pacemaker placement presents to the ED with a chief complaint of dizziness and shortness of breath. Her vital signs are T98.6, P42, BP 96/48, and SAO to 97% on RA. Her initial EKG demonstrates sinus bradycardia with occasional ventricular escape beats. No pacer spikes are observed. After a magnet is applied to the patient's pacemaker, a repeat EKG demonstrates a paced rhythm at a rate of 70 beats per minute. Which of the following is the most likely cause of the patient's pacemaker dysfunction? Oversensing. B. Impulse generation failure, failure to pace. C. Battery depletion. D. Failure to sense. E. Failure to capture. A. Oversensing. Answer A. Applying a magnet to the pulse generator causes the pacemaker to default to a synchronous pacing by turning off, or bypassing, the sense amplifier. In other words, a magnet turns the sensing function off. The pacemaker will deliver impulses, pacer spikes, at its predefined default rate, sometimes called the magnet rate regardless of the heart's intrinsic electrical activity. Since the pacemaker began pacing the patient's heart appropriately after magnet application, it is clear that it is generating impulses appropriately, and that those impulses are appropriately captured by the heart, i.e., the pacer spike evoked ventricular depolarization in the patient's heart as intended. Thus, the problem lies in sensation. The patient's pacemaker was misinterpreting signal, noise, as actual native activity when none was present. Since it detected what it thought was a native beat, it inhibited its output generation. This is called oversensing and is more common in single-lead devices.